online anesthesia video of this week. You can also participate in this program if you are interested. Just record your video presentation on Zoom platform and send to us in onlineanesthesia@gmail.com. For further rules and regulations, please visit our FB page online anesthesia. Let us watch this week's video.
Good morning, everyone. I am here to present the Applied Anatomy and Physiology of Neuraxial block. I am Dr.Ganessan. I am right now working as an Associate Professor of Anesthesiology in KAPV Government Medical College, Trichy. And I am holding the post of the President, ISU Trichy, and I have been the Secretary of ISU Trichy previously. Namely, which are the cervical and lumbar, which are convex anteriorly, and the thoracic curve is convex posteriorly. There are prominent bony landmarks which help you to identify the level of the spine. Namely, the vertebra of prominence, which is the C7, the prominent cervical vertebrae, and the root of the spine corresponds to T3, thoracic vertebra, and the inferior angle of the spine corresponds to T7. The superior aspect of the iliac crest, namely the intercrustal line, which is otherwise called the Tuffius line, corresponds to L4 or L4 at L5 vertebrae. This is the picture of the classical lumbar vertebrae. On the right side is the vertebral body. On the left side, which is marked as green, is the spinous process, and the superior and the inferior are the superior and inferior articular process respectively, and the laterally is the transverse process of the spine. The bone which is connecting the transverse process to the articular process is the lamina, and the bone which is connecting the articular process to the vertebral body is the pedicle. These are the different views of the same vertebra, and the hole in the center is a vertebral canal through which the spinal cord is going there, and it is protected by the bony parts on all the sides. This slide shows you the classical thoracic upper vertebrae and the lower thoracic vertebrae and the lumbar vertebrae in the anterior, posterior and the lateral directions. This depicts the position in extension and flexion. As you very well see, when the patient is flexed to facilitate spinal anesthesia, the interspinal space widens and allows a gap for which the spinal needle can enter into the subarachnoid space. There are 5 ligaments around the spinal column. The first is the supraspinous ligament, which runs along the apices of the spinous process of the vertebrae. The interspinous ligament, which connects in between the spinous processes, and the ligamentum flavum, which runs along the laminae, and this is the important landmark. Following the puncture of the ligamentum flavum, you enter into the epidural space. The anterior and posterior longitudinal ligaments of the vertebral body are placed anterior to the vertebral body and the posterior to the vertebral body respectively. The disc herniates usually through the weaker points in the posterior longitudinal ligament to enter into the area of the anterior epidural space. These are the structures which are traversed by the spinal needle before entering into the thecal sac. The first is through the midline approach, you enter into the skin subcutaneous fascia, the supraspinous ligament, the interspinous ligament, ligamentum flavum, finally pierces the dura and the arachnoid, which are closely adherent together to enter into the subarachnoid space. For the paramedian approach, everything is the same except you don't pierce the supraspinous and the interspinous ligament, rather than you pierce directly in the paraspinous muscle to reach the ligamentum flavum. Coming to the spinal nerves, there are 7 cervical vertebrae but 8 cervical segments in the spinal cord. The cervical spinal nerves emerge above the same numbered vertebral bodies, but C8 emerges between C7 vertebrae and T1 vertebra. The thoracic, lumbar and the sacral nerves exit the vertebral column below the same numbered bony segments. Regarding the innervation of the structures around the vertebral column, the facet joint is well innervated. Therefore, any problems with the facet joints will lead to low backache rather than we don't think usually of the disc herniation. The supraspinous interspinous ligaments are partially innervated and they produce less pain. Whereas the ligamentum flavum, the posterior lamina, vertebral body and spinous process are relatively pain insensitive. Coming to the meninges, the dura superiorly in the skull fuses with the foramen magnum. The caudal tip of the dura extends to the level of the S2. The dura is more thinner in the lumbar area. In spite of being thinner, it is still impenetrable by the epidural catheter when you put in epidural anesthesia. The dura is composed of collagenous laminae and elastin elements. The character is that it is freely compressible. Even a valsalval maneuver by the patient usually collapses the lumbar and thoracic dural sac and displaces the CSF rostrally. The clinical importance is that following a spinal anesthetic, if a patient violently coughs or does a valsalval maneuver, the anesthetic can easily spread rostrally and produce a higher level of spinal anesthetic blockade rather than what is expected to be there. The dura at times are separated by clefts which are filled with ground substance, which increases the dural permeability. Thereby, it allows the drug injected epidurally to easily penetrate the dura and reach the CSF. There are of course many fibrous strands predominantly which are located longitudinally and some are located circumferentially. The importance is that when you introduce a spinal needle into the subarachnoid space, the bevel of the needle should be directed laterally if the patient is in the sitting position, and the bevel should be facing the roof of the operation theatre when the patient is in the lateral position. This allows the dural fibers to be separated rather than transected. When it is done in such a manner, there is a decrease in the incidence of the post-dural puncture headache. Coming to the meninges, other meninges which are the arachnoid and the pia mater, they are a common embryological origin. They are similar microscopic structure, so they are called the leptomeninges. The arachnoid mater just lies immediately within the dura, therefore it cannot be separately seen most of the times. When you puncture the dura, you puncture the arachnoid mater too during a spinal anesthetic. The pia mater ends in the filum terminal. The dura is easily cleanly punctured, but the arachnoid is vellum and filmy, therefore at times it can give way. Here we see an example of a Whittaker needle where the hole is at the side rather than at the tip. In the first picture, the needle enters into the subarachnoid space, and when you inject the drug, the dura and the arachnoid are raised as a flap and the drug is easily deposited in the CSF. In the second case, when the anesthetist tries to aspirate the CSF flow, the hole is pushed out and it enters into the epidural space. When a low volume anesthetic like 3 or 2 or 3 ml injected into the needle, it enters into the epidural space and results in failure of the spinal anesthetic. In the third case, the hole is placed in between the layers of the arachnoid and the drug can enter into it, forming a potential space called the subdural space. But the subdural space is a misnomer because it is properly between the layers of the arachnoid. Here we are to discuss about the cerebrospinal fluid. 500 ml is formed each day. They are secreted by the choroid plexus of the cerebral ventricles. They reach the cisterns at the base of the brain and travel to the sagittal sinus. And there are defects in the dura which accommodate outward herniations of the arachnoid membrane. They are called the arachnoid granulations or the Pesonian bodies. The CSF circulation is like this, and the CSF get absorbed into the venous circulation. It's a one-way valve mechanism, and This one-way valve opens when the CSF pressure is more than the venous pressure, resulting in drainage of CSF into the venous channels. There is only minimal amount of cerebrospinal fluid in the spinal subarachnoid space, out of which only 50 ml will be there in the thecal sac out of the total 150 ml. As the secreted CSF comes down, they pass down posterior to the cord and they return upwards anterior to the cord. There are continuous oscillations of the CSF, more so in the cervical region and less in the lumbar region. These oscillations are due to the transmitted pulsations of the skull arteries. This facilitates anesthetic drug distribution when injected into the subarachnoid space and facilitates easy deposition and distribution of the drug either way. This is the composition of the cerebrospinal fluid. The important thing to be noted here is the plasma glucose value is there. As you know, it is usually 120. The composition of the glucose in the CSF is 2/3 of the plasma, maybe around some 80 milligram per deciliter. Suppose you have a doubt following a epidural anesthesia, the catheter is placed in the epidural space, and you doubt whether it is a CSF or the local anesthetic which has been injected, it is coming out. You can test just with the glucometer whether it contains glucose or not. If it contains glucose, it proves beyond doubt that it is only CSF. Yes, coming to the spinal anesthesia proper, the spinal nerves don't have the protection of the dura and the arachnoid, whereas in the epidural space, when the nerves exit out to the intervertebral foramina, they have the protection of the dura and arachnoid. And even a small amount of local anesthetic injected into the cerebrospinal fluid can produce profound block. The small roots have a larger surface area and the local anesthetic penetrates very rapidly. The spinal cord takes the local anesthetics by diffusion through the pia mater and reaches the superficial portions of the cord. The deeper structures of the spinal cord are reached through extensions of the subarachnoid space. The concentration of local anesthetic is higher in the nerve roots following a spinal anesthetic rather than in the cords. Coming to the order of blockade of the spinal anesthesia, the B fibers are the first to be blocked, resulting in blockade of the preganglionic sympathetic efferent, leading to sympathetic blockade, thereby hypotension. Next to be blocked are the C fibers, which carry the cold temperature sensation, and next to be blocked are the A delta, which carry the pinprick sensations. The A beta, which carry the tactile pressure and proprioception, are blocked next, and the A alpha, which carries the motor impulses, are blocked last. This is at the level of the cut section of the spinal cord. It shows the motor blockade is due to the anterior nerve root and sensory blockade is due to the posterior nerve root. You have to remember that L5 through S2 roots are the largest and the thickest of all the spinal nerves. They are the more resistant to local anesthetics, leading on to delayed action in spinal and sometimes absent blockade in epidurals. Now we can discuss about the anatomy of the spinal nerve root and the concept of differential blockade. This shows the cut section of the spinal nerve root where different fibers are arranged at different levels. As you see from the picture, the B fibers, which carry the preganglionic autonomics, are located at the outer surface of the spinal nerve. So they are the first fibers to be getting blocked in spinal anesthesia. And the next fiber placed is the C fibers. They are smaller in size and they are more sensitive, and they are also relatively on the outer surface of the spinal nerve when compared to the other nerves. So they are the first nerve sensations to be blocked, and they remain blocked for the longest period. Next are the A delta fibers, which carry the pinprick. They are the second to be blocked, and the last to be blocked are the A beta, which carries the touch sensation. This is regarding the sensations. And you can also see from the picture that the A alpha, which carry the motor fibers, are present in the innermost part of the spinal nerve. Therefore, the spinal local anesthetic takes longer time to reach the A alpha fibers. This differential blockade is due to the different anatomic and geometric arrangements of the individual fibers like B, C, A delta, A alpha, A beta and A gamma. And this differential blockade is also due to difference in the diameter of the nerve fibers. As you can see from the picture that the thickermost nerve fiber is the A alpha, which carry the motor impulses. They are in the size range of 12 to 20 microns. And the thinnermost nerve fiber are the C fibers, which are in the range of 0.5 to 1 micron. Therefore, being thin, the C fibers are easily blocked by even a lesser concentration of local anesthetic, whereas the A alpha requires a more concentration of local anesthetics. Therefore, in case of spinal anesthesia, where the patient is receiving a hyperbaric bupivacaine, more amount of molecules will be there in the lower part of the spinal column when compared to the upper column. Therefore, the motor blockade will be more on the lower part when compared to the upper part, where you have preferentially a sensory block. This is the concept of differential sensitivity. When the patient is receiving a spinal anesthetic, the patient will have loss of cold and temperature discrimination will be lost because they are blocked due to the sensitive C and sympathetic fibers. This blockade is 2 to 4 spinal segments above the pinprick, which is carried by the A delta. The pinprick is 1 to 2 segments above the level of the light touch, A beta, and the motor fibers, which are carried by A alpha. They are the largest fibers, they are the thickest fibers, and they are more myelinated, and they are less sensitive to local anesthetics. Their level of blockade is 2 to 4 segments below the sensory because more amount of local anesthetic is needed to anesthetize the thick motor fibers. This picture shows the distribution of the hyperbaric local anesthetic. They predominantly distribute towards the caudal aspect and some reaches the cephaloid aspect, but they are prevented from ascending further up due to the thoracic curvature of the spine. Here we see the distribution of the isobaric local anesthetic. The point of injection is called the epicenter. The local anesthetic equally spreads cephaloid as well as caudally without much caudal preponderance. This shows how the hyperbaric local anesthetic is getting distributed. Here we are going to discuss about the glass spine model. Here the thoracic, lumbar and the sacral curvatures are seen. Assume that the patient is lying on the lateral aspect. The upper point shows the injection of the isobaric local anesthetic and lower point shows the injection of hyperbaric local anesthetic. See how the isobaric local anesthetic spreads equally on both sides, whereas the hyperbaric local anesthetic preponderantly takes the caudal aspect and some spreads to the cephaloid aspect. Now the patient is turned from the lateral aspect to the supine position. Now the curvature of the spine prevents further ascent of local anesthetic above the level of T4. Suppose you have a patient for which you have administered spinal anesthesia and you feel the level is not up to the mark. You want a further higher level of blockade. You have to make the patient lie in the lateral aspect, which eliminates the curvature of the thoracic spine. Therefore, the spinal anesthetic can further spread up. Plainly putting the patient in the supine position and putting a head down position can help ascent of the spinal anesthetic cephaloid to at least some extent. But when you put on the lateral aspect, it helps you a lot. These are the characteristics which determine the level of spinal blockade. The height has not much of change except in extremes of height when the patient is more than 200 centimeters or less than 130 centimeters. BMI plays a major role rather than the weight, and the presence of abdominal mass, any tumor or pregnancy results in lesser CSF volume, thereby resulting in a larger spread of local anesthetic. The injection site, therefore injection at L3, L4 or L4, L5 doesn't have much impact. When you inject above the level of L2, L3 or at the level of L2, L3 results in a higher spread of local anesthetic. The speed of injection, unilateral spinal better with slow injection. The volume concentration of the local anesthetic doesn't have much effect. Only the increase in dose can result in higher spread and longer duration of spinal anesthesia. Here you have to see that there is a septum posticum, which is a membrane which extends from the posterior midline of the cord to the inner aspect of the arachnoid. It has got many fenestrated partitions. Sometimes cysts may form within the septum posticum. They are due to the saccular dilatations of the septum posticum. Sometimes when you inject local anesthetic into the subarachnoid space, the spinal anesthesia totally fails. It could be due to presence of such cyst within the subarachnoid space, and you might have injected into the cyst. Aspiration will relieve good CSF flow, but the spinal anesthesia spread won't be as much as desired. As the spinal nerve root exits the dural sac, it carries with it along a layer of the pile membrane, CSF, and the arachnoid membrane lining the dural cuff. This pile layer of the spinal nerve root is usually continuous with the perineurum of the peripheral nerve. Accidentally, when you inject a local anesthetic in the brachial plexus into the intrafascicular plane, this can travel into the subpile space, thereby reaching the CSF and the cervical part of the spinal cord, resulting in spinal anesthesia. Coming to the lateral extent of the CSF space, it extends along the posterior root ganglia and the nerve roots. There are root sleeves in the dura which act as portal for entry of local anesthetic from the epidural space into the CSF. Physiological responses to spinal anesthesia. Cardiovascular system is the most affected due to autonomic denervation following the blockade of the B fibers. When a higher level of neural blockage is achieved following spinal anesthesia, you have bradycardia due to unopposed vagal nerve innervation. Autonomic denervation will lead to sudden vasodilatation and decrease in venous return, thereby decreasing the cardiac output. As there is vasodilatation, it leads to decrease in the systemic vascular resistance. Bradycardia and hypotension has been reported when the block is very high at or above the level of T5. Cardiac output, however, gets compensated. It remains unchanged in normolemic patients. It is facilitated when the position of the leg is elevated above the level of the heart, which improves the venous return and thereby improves the cardiac output. As far as spinal anesthesia is concerned, the myocardial oxygenation is balanced. Even though there is spinal hypotension leading on to decrease in the coronary blood flow, which decreases the oxygen supply, but the demand is also substantially reduced. There is decrease in afterload due to fall in systemic vascular resistance. The left ventricle workload is decreased. There is also decrease in preload because there is decrease in venous return, and the workload of both the left ventricles and the right ventricles are decreased. Heart rate is also lessened due to the unopposed vagal innervation, thereby reducing the left ventricular workload. As the frequency of contraction diminishes, the oxygen demand is also decreased. Therefore, the demand is decreased, the supply is decreased, but the myocardial oxygenation is balanced. Coming to cerebral blood flow, autoregulation maintains the cerebral blood flow within a range of 50 to 150. When the MAP is less than 50 to 55 millimeters of mercury, the flow is pressure dependent. There is only 10% decrease to the hepatic blood flow, which is not significant. The ventilatory responses, tidal volume, inspiratory volume, and negative intrapleural pressure are unaffected. Maximum breathing capacity and maximum expiratory volume are diminished significantly. The patient cannot cough or clear his secretions, and the muscles of forced exhalations are paralyzed. The cause of the transient respiratory arrest following high spinal is usually due to ischemia of the medullary respiratory neurons following a severe fall in BP and cardiac output, which impairs the cerebral blood flow. Phrenic nerve is usually unaffected most of the times, even up to a level of block of mid-cervical sensory anesthesia, even when the sensory anesthesia up to the mid-cervical level, but the motor level is expected to be below. Therefore, phrenic nerve motor blockade is unlikely. Sedation occurs following spinal anesthesia. It can be observed more so in elderly patients because there is depression of the excitability of the reticular thalamic cortical arousal mechanism. The proprioceptive impulses from the lower limbs are constantly transmitted upward to the reticular activity system and reach the cortex of the brain and keep the patient awake. When everything is blocked, this activation is put at standstill, and sedation, even small amount of sedation can lead to profound sedation in elderly patients especially. Hypothermia in spinal anesthesia is there because shivering is limited only to the unblocked segments, which is a compensatory phenomena. When the block is very high, we have only limited segments, unblocked segments left to compensate in the form of rigors. There is some amount of residual peripheral vasodilatation in spinal, and faster periphery to core heat transfer is expected in spinal, but core temperature correction is faster than general anesthesia. Coming to the drugs, lidocaine is absorbed through single first order absorption process, whereas bupivacaine, lipophilic drug, first metabolism is absorption, which is equivalent to lidocaine. The slower one, slow absorption, is from the epidural fat. As age increases, there is a faster onset of spinal anesthesia. You expect a higher level of blockade due to calcification of the paraspinal muscles and the ligaments, and the spinal anesthetic is long lasting because the local anesthetic takes a longer time to get cleared from the spinal canal. In elderly, the nerves are vulnerable to local anesthetics. The myelinated part is decreased. There is already sensory neuron loss due to age, and the conduction is also very slow in motor nerves. These are the risk factors for bradycardia: low baseline heart rate, patient on beta blockers, block above the level of T6, prolonged PR interval, ASA 1, and age less than 60. These are the two reflexes which account for the bradycardia after spinal anesthesia. When there is severe hemorrhage, vigorous contractions of an underfilled heart may initiate the Bajal-Joris reflex, resulting in bradycardia. And when there is decreased venous return, which can be detected by the atrial stretch receptors, it can result in bradycardia. It is called the reverse brain bridge reflex. These are the risk factors for postspinal hypotension, hypovolemia, preoperative hypertension, high sensory block, age more than 40 years, obesity. BMI plays a major role rather than just increase in weight. Combined general and spinal anesthesia, chronic alcohol consumption, and urgency in non-obstetric surgeries. The epidural space is a space outside the dural sac but within the vertebral canal. The boundaries are walls of the vertebral canal. Anteriorly, you have the vertebral body and the disc, laterally the pedicles, posteriorly the lamina and the ligamentum flavum. This picture shows the epidural fat. The epidural fat is usually fluid in texture. This is non-adherent surfaces. It permits gliding movement of the neural structures, producing a padding effect. The dural sac inferior to L4 and L5 disc and the sacral canal tapers. It's smaller in size due to increase in the epidural fat. There is difficulty in delivering local anesthetic to L5 and sacral roots during epidural because of the increase in the epidural fat. Epidural steroid injection for back pain, chronic back pain, can lead to epidural lipomatosis, thereby increasing in the epidural steroid contents. Coming to the posterior epidural compartment, it is the space as you approach from the posterior aspect. This compartment is largest at the mid-lumbar level, decreases in AP diameter at the thoracic levels. Rostral to C7 level, the posterior epidural space vanishes completely. The posterior dura is in contact within the ligamentum flavum. The posterior epidural fat thins laterally and the dura contacts the ligamentum flavum in the lateral aspect. The native posterior epidural fat space is without fibrosis. Fibrous proliferation can occur following laminectomy. Therefore, following laminectomy, when you attempt an epidural, due to fibrosis, it may be difficult for you to pass the epidural catheter, and even a single shot epidural can result in failure of the local anesthetic to reach the desired levels. Coming to the negative pressure in the epidural space, it is due to the opposing non-adherent tissue planes. Subatmospheric pressure is generated by the usual action of the lymphatics and the balance of the osmotic and hydrostatic forces across the capillary endothelium, which is called the Starling's forces. This is the reason for aspiration of a hanging drop when you approach the epidural space. Coming to the action of the epidural drug and spread, the drug injected into the epidural space can cross the dura through the weak points, and it can diffuse across the dura to the CSF, and they act at the intervertebral foramina where the dural sleeves are less and can easily penetrate into the spinal cord. Superiorly, the drug can diffuse across the dura into the CSF. They even diffuse across the dural cuffs, which are where it is the origin of the spinal nerves. Inferiorly, it can spread even into the sacral foramina, and laterally it can spread into the paravertebral space. It's a similar picture showing the dural cuff root sleeve region, where the drug from the epidural space can enter into the subarachnoid space. Coming to the lateral epidural compartment, this compartment forms just medial to each of the intervertebral foramina between the pedicles. It is filled with the segmental nerves, vessels and fat. The pressure in the epidural space is usually a reflection of the abdominal pressure, because the flexibility of the tissues occupying the lateral epidural space, the lack of the rigid barrier in the intervertebral foramina lead to easily transmission of pressure from the abdomen into the epidural space. The anterior epidural space, the fascia of the posterior longitudinal ligament. As you already know that the posterior longitudinal ligament is posterior to the vertebral body, and the fascia of the posterior longitudinal ligament that completely separates the anterior epidural compartment from the rest of the vertebral canal. It blocks the spread of the injected local anesthetic. It prevents it from spreading into the anterior epidural space. It funnels the solution towards the spinal nerves. Internal vertebral plexus will be there in the mid portion of the vertebral body. It is called the basivertebral vein. Sometimes the epidural catheter can transgress from the posterior epidural space into the anterior epidural space through the posterior longitudinal ligament and enter this basivertebral vein. This is the cause of bleeding into the epidural catheter. Sometimes you have a continuous aspiration of blood following epidural catheter insertion. The cause could be the catheter from the posterior epidural space would have entered the anterior epidural space and pierced the posterior longitudinal ligament to enter into the basivertebral vein. As you see, the PLL is a posterior longitudinal ligament which is in the anterior epidural space, and the structure marked as blue is the basivertebral vein. This is what we have discussed. Solution injected epidurally via the posterior epidural space, spread circumferentially, passes out of the intervertebral foramina, also passes longitudinally within the vertebral canal. Even catheter tip, if it accidentally extended exterior to the intervertebral foramina, even if it is placed in the paravertebral space, the injected solution can preferentially come back and spread in the vertebral canal. Any block around the vertebral column, maybe in the brachial plexus, stellate ganglion, intercostal, paravertebral, can even reach into the epidural space. Therefore, the paravertebral block is another extension of the epidural anesthesia. Coming to the cardiovascular changes produced by epidural anesthesia, if the blockade is between T6 to L1, there will be dilatation of the splanchnic bed. This is compensated by vasoconstriction of the unblocked segments, mainly brought about by the adrenal medullary system, which compensates for the venous and the arterial dilatation. When the cardiac accelerator fibers, that is namely T1 to T4, are blocked, it leads to decreased cardiac contractility and bradycardia will be the result, thereby resulting in decreased cardiac output. Venous pooling, as you know, there will be resulting in reduction in cardiac output with higher nerve blocks, and thoracic epidural anesthesia or anesthesia reduce the left ventricular contractility and minimally reduce the SVR, but it preserves the right ventricular function. There is improved myocardial blood flow and myocardial oxygen balance in epidural analgesia. The anti-anginal effects and decreased postoperative arrhythmias for any major cardiac thoracic surgeries following epidural anesthesia an advantage. Regarding the action on the G80 and the respiratory system, if you have a blockade of between T5 to T12, unopposed vagal tone result in increased peristalsis in rack sphincters and increased GA secretion. But this is of course more of a theoretical one, and thoracic epidural anesthesia has known to decrease the incidence of anastomotic leakages and improves the perioperative intestinal perfusion, thereby helping in recovery. Benefits therefore are more with thoracic epidural and less with lumbar epidurals. The net positive effect on the lung function in thoracic epidural anesthesia helps the patient recover in the postoperative period, and the pain reliefs also prevents the splinting of the diaphragm. Neurohumoral responses are many following the surgical and the catabolic states. There is increased catabolism and oxygen consumption, increased plasma catecholamines, and other stress hormones are increasingly produced. Increased left ventricular afterload is there. Plaque instability can lead to myocardial event. All these effects are elevated and help in prevention of any untoward events by the neuraxial anesthesia, namely the spinal and epidurals. It is what we think we know already that often prevents us from learning. Thank you.